Good morning, everyone. We'll be starting here very shortly. We'll wait one more minute and then we'll get started.
Those are the two, Leopold, that we wanted to really emphasize.
All right, we'll go ahead and get started. Well, welcome everybody to this COVID-19 Clinical Updates webinar hosted by USAID's Sustaining Technical and Analytic Resources team and the University of California, San Francisco, with support from USAID's Oxygen Ecosystem Initiative. Over the next hour, we're going to be talking about pulse oximetry. We're going to talk about the fundamentals of how it works, some of the limitations in technology that have been highlighted by recent publications, and also practical aspects of implementation, including implications on oxygen consumption and resource variable settings. There's going to be two presentations followed by Q&A by a panelist of leading global experts on the topic who I'll introduce momentarily. Before we get started, I'd like to turn over to Dr. George Cybury, who is the lead for USAID's Oxygen Ecosystem Initiative. George.
Thanks very much, Dr. Lipnick. Are you able to hear me okay?
Yes.
Excellent. I just want to welcome everybody to this next in the series of webinars and to appreciate Dr. Lipnick and his team at UCSF STAR, a project that we think is very valuable, and appreciate all of the partners and staff who are working hard to really address this critical and life-saving part of the response to COVID. I think the topic today is extremely relevant, extremely important, and I'm really looking forward to it. Dr. Lipnick, back over to you.
Thanks very much, Dr. Cybury. Just as a reminder, we are recording this session. And also as a reminder, the information and the resources here do not represent medical advice or clinical consultation. It's intended to be educational in nature. We'll ask that everybody remains on mute, but we are broadcasting in English, Spanish, and French. So please, at the bottom menu of your Zoom console, select the language that you prefer. We'll also be recording in all three languages, and the recordings will be posted online. If you have questions during the presentation or during the Q&A, please use the Q&A or chat feature, and we'll field those questions at the end after the presenters have finished. Finally, as a reminder, these webinars take place on the second and fourth Tuesdays of the month, and topics can be requested by contacting either myself directly or Lauren Wall. Finally, as a reminder, some of the tools and resources that are highlighted by our presenters or during the Q&A can be found on some of the portals that have been created as part of this project, including opencriticalcare.org, the COVID-19 Treatment Guidelines Dashboard, and covidprotocols.org, which have been supported by USAID, STAR, and in collaboration with many partners, including Partners in Health and Brigham and Women's Hospital. So as we get ready to hear from our first panelist, I'm going to go ahead and introduce all of our speakers and our panelists. Dr. Phil Bickler is a professor of anesthesiology at UCSF. He's also the principal investigator for the UCSF Hypoxia Lab, which has been a global pioneer in pulse oximeter development, including the accuracy of devices, as well as some of the seminal papers that have led to the development of the current technology. Dr. Wangari Waweru-Sika is a clinical associate professor of anesthesia and critical care at the Aga Khan University in Nairobi. Her research interests include quality of care and critical care outcomes in low and middle income countries, with a focus on identifying cost-effective interventions that guarantee good outcomes in the critically ill. She has also currently been involved in the establishment of the first ever critical care registry in Kenya. Dr. Teo Twagiru Mugabe is a consultant anesthesiologist at the University Teaching Hospital of Butare and professor of anesthesia at the University of Rwanda. He was co-PI on the Kigali modification of ARDS study that utilized pulse oximetry in lieu of arterial blood gases for the management of ARDS. His research interests also include upgrading critical care and resource variable settings to meet international standards. He's co-authored multiple articles on the Kigali modification of ARDS, the evaluation of severity and mortality prediction scores in ICUs in low-income countries. And finally, Dr. Beth Riviello, Assistant Professor of Medicine and Critical Care at Beth Israel Deaconess Medical Center at Harvard University. Her research interests are focused on ARDS, sepsis, and mortality prediction in low-income countries. She has particular interest in examining how context impacts critical care epidemiology, interventions, and outcomes. Special thank you to all of our panelists for joining. And next, we'll hear from Dr. Phil Bickler. Dr. Bickler, over to you. I believe you're on mute, Dr. Bickler.
Thank you, Dr. Lipnick. I appreciate the opportunity to share with you some of the things I've learned about how pulse oximeters work, how they perform, and ways of thinking about limitations in what pulse oximeters can do for us. I don't have any significant disclosures this morning. My key messages today will describe the way that pulse oximeter has become the essential tool for diagnosing hypoxemia, the non-invasive nature of the technology, and the low cost of pulse oximeter instruments have positioned it as a transformative monitor everywhere on the planet. I'm going to talk about the technology that underlies the measurement technique that pulse oximetry uses. And probably most importantly, I'm going to talk about some of the important limitations that is inherent to the technology, that these limitations are extremely important to appreciate as groups like this work to disseminate the technology across the planet, especially in resource-limited settings. Let's start with some basics. So what pulse oximeters do is they measure something called functional saturation of hemoglobin with oxygen. So it's the percentage of the available hemoglobin that is bound to an oxygen molecule. It's different from fractional saturation. It's different from partial pressure of oxygen that one would obtain with an oxygen electrode and a blood gas. There's a related terminology called pulse co-oximetry, in which the technology has been expanded with different wavelengths of light to measure hemoglobin moieties like methemoglobin, carbon monoxide bound hemoglobin, and even total hemoglobin. In the typical configuration, pulse oximeters display measurements of more than just more than just fractional saturation or SpO2. They also deliver information on the heart rate, and many of them, especially ones that are found in hospital settings, report some information about the signal quality. And the pulse signal that's obtained is called the photoplethysmogram, and it can be used to provide an index of perfusion in the region of the body that the pulse oximeter probe is applied to, as well as the variability in the perfusion, a parameter called the pulse variability index that can be very useful in detecting changes in the vascular volume status of a patient. The history of measuring oxygen in the human body is quite interesting. As technology often is, it's driven by other changes in society. And World War II was sort of a seminal event. The British were trying to design warplanes that could ascend to very high altitudes. And so it became important to measure the oxygen level in pilots. And on the upper left is a device that was developed for the RAF in around 1940. In the US, Millikan developed a device that he attached to the ear of pilots. It basically was a light attached to the earlobe, and it was connected to a pretty bulky vacuum tube, including a device which measured, more or less accuracy, something related to the oxygen level in a pilot's blood. A transformative event occurred in the late 1950s with our mentors John Severinghouse's development of the world's first blood gas analyzer, where it combined an oxygen electrode to measure PO2, a CO2 electrode, as well as a pH meter. Really, in the world of pulse oximetry, it all began in 1975 with a Japanese inventor at Nihon Kohden Corporation. He was Takuya Oyagi, and the pulse oximeter that he developed became the foundation for pulse oximetry worldwide. And as you know, pulse oximeters are now disseminated all over the planet, but there remain tremendous gaps in the availability of pulse oximetry in operating rooms and other acute care settings like the ICU. Here's a picture of Dr. Oyagi when he visited our laboratory in San Francisco. He passed away last year in his late 80s. He received just about every engineering award you can imagine for developing one of the most important medical devices in the last 50 years, I would say. And on the right is our mentor, John Severinghouse, in the operating room. He was always inventing things. He loved to bring technology to new use in medicine. Dr. Severinghouse founded the Hypoxia Research Laboratory at UCSF. I mean, his interest in oxygen was not only in measuring oxygen in blood, but also in the ways that humans adapt to high altitude. We've continued that legacy and have published a number of papers that we think have had an impact on driving forward the idea that oximeters should be better and that current technology has limitations that need to be addressed, both for clinical accuracy and health equity. Well, let's talk just some fundamental things about the way pulse oximeters work. I mean, fundamentally, pulse oximeters are a device that can detect the color of blood. And the blood tubes there show the difference between deoxyhemoglobin and oxyhemoglobin. The colors can be even perceived by the human eye. But what the pulse oximeter does is it quantifies those color differences and provides a more or less accurate estimate of the amount of oxygen that is bound to the blood. Well, it's a little bit more complicated than just measuring the color. Dr. Oyagi's innovation that transformed the non-invasive measurement of oxygen bound to hemoglobin was the concept that you could use the signal from pulsatile blood and non-pulsatile blood to create an index which would be related to the oxygen that's bound to hemoglobin. The basis for this is that the light absorption by oxyhemoglobin is different than reduced hemoglobin. Reduced hemoglobin is HHB, oxygen-bound hemoglobin is HbO2. And at two different wavelengths here, around 650, 660, and 800, the two species of hemoglobin absorb light differently. And if you express what's called the AC component, that is the pulsatile component, over the DC component, the non-pulsatile component, at the two wavelengths, you can create an index which is related to oxygen saturation. And that index is called R. So it's really the ratio of two ratios that's related to this. Now, expanding the technology beyond just these two standard wavelengths of red and infrared light allows you to do a lot more things. Plotted on this chart are the absorbance spectra of methemoglobin, oxyhemoglobin, reduced hemoglobin, and carboxyhemoglobin. So, in principle, one could use different wavelengths of light to solve multiple simultaneous equations to derive values for all of these. And there are a few manufacturers that have done this and incorporate between 8 and 10 different wavelengths of light from light emitting diodes to produce sort of a spectrophotometer that goes on a finger. One of the things about this technology is that the light signals and the derived values from the light signals, from applying various equations to them, is that it doesn't tell you an absolute number for the saturation. What has to be done is an in vivo calibration. And despite lots of development of benchtop models of human blood, it remains in 2021 necessary to do testing in living humans, to make humans hypoxic and to draw blood samples and to compare the true saturation measured with a heme oximeter with the value from the pulse oximeter. Then the pulse oximeter's algorithms are calibrated to accurately reflect the oxygen saturation. Now, in practice, the relationship between the output of the oximeter and the true saturation varies with some known quantities, and they include the quality of the optics, the quality of the light emitting diodes that are used to produce the colors in the probe, the physical layout of the sensor and its material matter. And a factor that I'll talk more in detail about in just a minute is the skin pigment. Melanin can interfere with the accurate measurement of oxygen with a pulse oximeter, and so has a significant bearing on how oximeters perform and their reliability and accuracy. So I mentioned a moment ago that pulse oximeters basically have to undergo final calibration in studies in hypoxic humans. And so we have developed techniques to create stable levels of very profound hypoxemia in subjects that have an arterial line placed to obtain blood samples. And these techniques have been used safely for a long time. I mean, I could spend the entire time just talking about the effects of hypoxia on humans, aside from pulse oximetry. But in our studies thus far, we have enrolled about 7,000 subjects and subjected them to pretty profound hypoxemia. And our experience has strongly indicated that these studies are safe and provide a very valuable way of testing the performance of oximeters. They provided insights that have been very useful to us in describing what happens with hypoxia during COVID-19 disease. Here's just a sketch of the laboratory environment. There's a subject on the right there breathing through a mouthpiece. This subject is given reduced amounts of air to breathe, and there's carbon dioxide added, and we're monitoring the oxygen level in the body breath by breath. So we're sampling end-tidal gas that we derive end-tidal carbon dioxide, end-tidal oxygen. We use a computer algorithm to estimate the saturation in the arterial blood. We can get very close to the desired level of arterial oxygenation with this technique. And even more important, we can do it in a way that's stable. So it provides a test bed for any sort of oximetry device that is being evaluated. Next. So data from a typical pulse oximeter validation study might look like this. So the red trace on the bottom is the subject's heart rate. And at the top in gray are the readings from a test pulse oximeter. So we achieve different levels of hypoxemia. In this case, we start near 100%. We dip down to around 70% in 2 runs. You can see there's an initial dip down in the gray dots, and then it comes back up, and then we do another dip down. The blue dots indicate the points in time where we take arterial blood samples. At those points, we have a pair of points between what the oximeter is reading and the true value of oxygen saturation measured on that blood sample. So at those moments in time, we can assess the performance of the oximeter. Next. So the way we think about performance is fairly standard. You can imagine that a device reads accurately with very little variability, right? It always measures true. So that would be represented by the target in the lower right, where it's both accurate and precise. And the upper left is sort of the other extreme. The readings vary from the true value, and they vary from the true value in sort of a random way. So that instrument would be considered not accurate or precise. The upper right shows an instrument that on average is accurate. If you average all those bullet holes, it comes out that it hit the target, but it's not precise because there's scatter in the data. And so we use indices of what we call bias and precision. So precision is how consistently the instrument is performing, and the bias is the average deviation in the reading from the true value. So you can imagine that a device is very, very biased, but it's always wrong by the same amount. So it's precisely wrong. It has bias and it's precisely off. So it's consistently off. And you can see how these considerations can get a little esoteric and become the realm of statistical experts. But I think the general idea is kind of clear. Next. Here are data from a typical study. And this is called a bias plot, where the vertical axis plots for each data pair, that is the blood sample and the oximeter reading, the difference between the blood sample and the reading on the oximeter. And then the horizontal axis is the true value of the saturation as measured with the benchtop hemoximeter from that blood sample. And as is typical of many oximeters, the data in this experiment show that the 95% confidence intervals splay out at lower saturation. So this instrument has a average bias that's pretty close to 0. But notice how the scatter of points increases quite a bit at low saturation. So at low saturation, at values between 70 and 75, there's a lot of variation in the bias among different subjects in this study. Next. Some oximeters do very, very well. This is an example of an oximeter that performed pretty well. This is sort of the potential of what a good oximeter can do. Next. Many factors affect the performance of oximetry. Some of the things that are most important are low perfusion, movement by the subject, anemia, and dark skin pigmentation. Let's go on to the topic of dark skin and how it can impact the performance. So pulse oximeters use light-emitting diodes, which put out red light at around 660. Melanin absorbs in the same path. So what melanin can essentially do, because the LEDs produce a spectrum of light, they basically filter the light and they alter the calibration of the instrument. So this can be a big problem with dark skin. Next. Back in 2005, we were among the first to recognize this. These are data from a study we published in Anesthesiology, which showed that in darkly pigmented subjects, the oximeter bias is such that the instrument reads too high at low saturation. So what that means is you miss hypoxemia. This was known in 2005, and we tried to disseminate that information widely. We had various degrees of success. Next. In a recent article in the New England Journal of Medicine, this issue was brought to the fore once again. Michael Schoeding and colleagues at the University of Michigan published data showing that in darkly pigmented patients, not subjects, but patients, that pulse oximeter readings frequently were too low. You can see the difference between arterial oxygen saturation measured with a blood gas and with oxygen saturation measured with a pulse oximeter. Let's have the next slide. I can explain more of this. So the left is Schoeding's patients in the clinic. There's something going on. On the right are data from laboratory studies using the methods that I described earlier. You don't see the same issue. You see the same direction where pulse oximeters read too high in darkly pigmented subjects, but you don't have as much scatter. So now the focus is on what is it about clinical settings that amplify the bias in pulse oximetry? What factors based on race are doing this? Are the patients sicker? Do they have lower perfusion? It could be a number of factors. Next. So we are actively working on this. And as I said, we've had a mixed history of success in getting manufacturers to account for this, this bias. Next. Other factors that can affect performance is motion. So we have motion testing protocols and anemia. The device at the right is something that Dr. Lipnick built to model anemia. Those are among the studies that are ongoing in our laboratory. Next slide. So inexpensive pulse oximeters raise a really good question. These are the oximeters that are being widely used in the COVID pandemic, and they're more frequently found in resource-limited settings. Many of them have significant limitations, and Dr. Lipnick's work has highlighted some of the errors that can occur. It gets on the next slide. Yeah, Mike did a really nice study a few years ago that became the most highly cited paper from this journal in that year. And all this attention was drawn to it as the COVID pandemic started. So congratulations for Mike for that very high impact work. And we need to do more work on these inexpensive oximeters. I mean, there's so many of them out there. They're everywhere now. So I'd just like to wrap up by saying that we have a lot of work to do. We know how to improve pulse oximeters. We have some specific ideas about how the issue of skin pigment can be addressed. There are both clinical studies and laboratory studies that need to be done, all in the service of producing oximeters that are accurate, inexpensive, and easy to use. And I think that's just about concludes my remarks. I believe that I've told you a little bit about how pulse oximeters work. I've told you about some of the limitations in the technology. This is some of the members of the current research laboratory. If you're in San Francisco, come by our lab. I'll put an arterial line in you and make you very hypoxic. Thanks, everyone.
Thanks so much, Phil. And as we're getting ready for Dr. Riviello's talk, please don't forget to put questions in the Q&A, and we'll get to those in about 15 minutes. And without further ado, Dr. Riviello and colleagues, over to you.
Great. Thanks, Mike. I'm going to be speaking on behalf of Dr. Teo and Dr. Wangari as well, with a few additional topics. So we're going to talk about the role of pulse oximetry in managing acute respiratory distress syndrome, or ARDS. We're going to talk about ideal oxygen saturation targets, both in terms of individual patient benefit as well as population benefit in conservation of oxygen. And then finally talk about continuous versus intermittent pulse oximetry. Just to get to the bottom line first, Pulse oximetry is a reasonable alternative to invasive arterial blood gases to diagnose and treat COVID-19 ARDS. And it's important to note that the saturation on the pulse oximeter should be less than or equal to 97% to maintain accuracy. The second main point is that probably a target between about 90 and 96% is good both for patient outcomes as well as for conservation of oxygen. And then finally, that while intermittent pulse oximetry certainly may miss hypoxemia, there are things we can do to mitigate that risk, and we'll talk briefly about those. So first, talking about ARDS and some work that Dr. Teo and I have done around this. So just to, for those of you particularly who are not clinical, ARDS, or acute respiratory distress syndrome, is a syndrome of inflammation in the body that is in response to some acute insult, and it causes inflammation that then causes leaky vessels and fluid in the lungs. So you can see on your left a normal lung, all that black area is air, as it should be. On the right is an ARDS lung with fluid being all that white stuff that's filling in what should be air, and it causes hypoxemia. So just to note, almost any insult can cause it. It can be directly in the lungs, like bacterial pneumonia, or viral pneumonia like COVID-19, any other infection in the body, trauma, burns, surgery can do it. Anything that inflames the body can cause ARDS. But the reason we care for this group is because pretty much all COVID-19 pneumonia is ARDS. And when we are talking with partners about how to diagnose, how to manage COVID-19 pneumonia, really almost everything that we are using is what we know about treating ARDS. A problem is that ARDS historically has been defined and diagnosed using blood gases, which requires usually an arterial line, an ongoing intravenous line, except that it's intra-arterial, and ongoing laboratory measurements, rather than the pulse oximetry, which, as you know, is a non-invasive device that can stay on the finger or on the ear or forehead. Historically, also, ARDS research around things like proning, paralyzing, the things we do for ARDS, has used blood gases to determine severity of illness, so who would benefit, for instance, from things like proning. The definition of ARDS that we currently use is called the Berlin definition, because it was formed by a group of experts in Berlin in 2012. And it requires blood gases to get a severity of hypoxemia, what we call a P to F ratio. It requires chest X-ray or CT scan in order to define it. You have to have puffiness on both sides of the lungs. And it requires the patient to actually be on a ventilator, whether non-invasive ventilation or invasive, in order to meet the definition of ARDS. What Dr. Teo and some other colleagues of ours did was to redefine ARDS with a Kigali modification, because we did it in Kigali in Rwanda. And the idea was that ARDS ought to be able to be diagnosed without the technologies that the Berlin definition requires. We actually made a few modifications. We said you don't have to have a chest X-ray. You can use ultrasound, which is more available. You also don't need to be on a ventilator, since they're not available to most people. But importantly, we also said instead of blood gases, you can use an estimation based on pulse oximetry. And since we did this, there's actually been better modeling, so that the estimates of blood gas oxygenation from pulse oximetry are even better than they were in 2016 when we published that study. Again, just important to note that the saturation needs to be less than or equal to 97% on pulse oximeter to be accurate. All of you, I think, are familiar with opencriticalcare.org, and what Dr. Lipnick and colleagues have done is to take these models that use pulse oximetry to get us to the point of ARDS diagnosis, and they've put a simple calculator into Open Critical Care. So you can simply put in the saturation of the patient, how much oxygen the patient is on, and you can get the information you need to both diagnose and treat COVID-19 ARDS. Something that I think is of interest as well, this is even before COVID, but pulse oximetry with SpO2 is actually being used more and more in high income settings as well. This is not just in resource variable settings, but also in high income countries. So this is the ROSE trial in the New England Journal, one of the more recent important studies around ARDS in 2019. And they actually had almost 10% of the patients in the study were allowed to be in the study based on pulse oximetry rather than blood gases. And it's this recognition that perhaps we really don't need to be placing invasive lines in order to treat this syndrome. Another example of why this is being used more in high-income settings, this is an email that I received about a year ago where my own hospital in Boston had an ABG syringe shortage. So we began using, as a practice, pulse oximetry rather than blood gases as a way of estimating hypoxemia for COVID-19 patients. And I would say even in the setting of our having more syringes for blood gases again, we've continued to rely more on pulse oximetry. So the implications are that blood gases are used for defining ARDS. They're also used to decide how severe ARDS is, to know which types of therapies to use, such as proning. But that pulse oximetry really can enable us to diagnose ARDS, including COVID-19 ARDS, and to treat it without blood gases. And again, this caveat that the saturation needs to be below 97%. I want to talk briefly also about oxygen saturation targets for acutely hypoxemic patients, including those with COVID-19. So in terms of individual patients, what is the ideal oxygen saturation? I think we all know that hypoxemia is bad, although Dr. Bickler did say you can be hypoxemic for short periods with no harm, which is absolutely true. If you stay hypoxemic, you in fact die. We know that the body cannot survive without certain levels of oxygen. I put up this study. It's a very nice study from Papua New Guinea. There are no studies in adults, but this is a before and after study demonstrating that the introduction of pulse oximetry and oxygen concentrators actually reduced mortality for childhood pneumonia in Papua New Guinea. But what about hyperoxia? What about too much oxygen? And we think that is also probably bad. In animal studies, we know that reactive oxygen species can damage the lung. You can get something we call absorptive atelectasis from too much oxygen. So we know that probably too much oxygen is also bad. In terms of clinical outcomes in patients, there's actually been a lot of work done on this in the last few years. The top two studies in critical care medicine in JAMA in 2016, as well as two studies that came out in tandem in the New England Journal just last year in 2020, addressed this question. And they show varying outcomes. So you can see the one study from 2016 had no difference in outcomes. Another one in the New England Journal also had no difference in outcomes. One study actually showed that a lower oxygen target was better in terms of mortality for patients. And then there is this one French study that actually showed that maybe higher targets was better. Although it's important to note that that study was stopped after only 200 patients and that it also used quite a low saturation target, which may have impacted the results. This study is the most recent, and I think kind of what I consider to be the definitive study that we have so far, at least. The New England Journal, just about 6 weeks ago, was published lower or higher oxygenation targets for acute hypoxemic respiratory failure, which is where COVID lies in terms of a syndrome. And in this study, they used 3,000 patients, and they saw no difference between high or low saturation targets. And just to give you an idea, the saturation targets between the two groups, there was a median of 96% saturation in the higher group and a median of 93% in the lower group. So not very different, but certainly a separation in how much saturation each group had, but no difference in mortality. To give you an idea of what current guidelines say, the NIH in 2020 says for COVID that 92 to 96% is reasonable based on the data it had at the time. WHO, when it talks about severe acute respiratory illness, including COVID, actually says a lower target, 88 to 93%. So I think for individual patients, there's obviously not a clear answer, what is ideal, but I would say somewhere in the 90 to 96% range is probably safe and effective care for patients, not hypoxemia and not hyperoxia. But what about the population? What about resource variable settings where you actually could be at risk of running out of oxygen? What should we be doing? Is there anything we can do to conserve oxygen to get the most bang for our buck as we're introducing oxygen sources into areas that don't have enough? And this is actually a question that Dr. Teo and our group and I asked a little bit ago in Rwanda. So we looked at the just right amount of oxygen, not only for the patient, but also for the system. And the reason we did this is because our previous study on ARDS in Rwanda revealed a few things to us. The first was that there was a 50% mortality among all hypoxemic patients. This was not ICU patients, not severely hypoxemic patients. This was any patient who was hypoxemic at all. Half of them died in the hospital. We also found that 60% of those patients had at least one day when they were getting inadequate oxygen. In other words, their saturation was less than 90% when they were checked on a day. We also found from talking with nurses that the target saturation that was being used was 100%, that there wasn't a clear goal and that was what the nurses were assuming. And we also became aware that oxygen shortages at that time in the hospital were common. So we had a theory that perhaps if you could titrate saturations lower, maybe there would be fewer shortages and perhaps there would be fewer patients who are hypoxemic on one day or more. So this is the University Teaching Hospital of Kigali, a 560-bed hospital with about 12,000 admissions per year. This is what the wards look like. And this was the PSA plant at the time. There was one plant producing 70 cylinders per day, and in general, the hospital had 50 cylinders of backup. So we did some very simple teaching, both for nurses and doctors, about why we should use saturation targets. We taught everyone how to use the pulse oximeters. And we had reminders around the emergency department about the saturation goal. In this case, we used 90 to 95%. And we found that about 12% of patients were hypoxemic. They were young, as we expected. About a quarter ended up on a ventilator at some point, and mortality was very high, just as we had found before. But importantly, what we wanted to know is, could we be effective in this intervention? So we found that at the beginning, the number of patients who were hypoxemic was about 12%. And in fact, after the intervention at week 4 and week 12 periods, there was in fact fewer patients who were hypoxemic in the emergency department. We also found that the patients who were hyperoxic, who were greater than 95% reduced, and that those who were in the target range had a significant increase in proportion. We also wanted to know about oxygen consumption and availability. And we did find that the number of oxygen tanks used per day in the emergency department consistently went down after the intervention and even got better at week 12. The number of oxygen tanks on reserve for the hospital each day went up, which is what we expected, and it was about equal between weeks 4 and 12. And the number of days with critical oxygen shortages went down. And I'll note that at week 12, you'll notice that there's a bump up from where it had been. But in this week 12, that's actually a month-long period. And one of the weeks in that month-long period, the PSA plant was not functional at all. So even in the setting of missing a week of oxygen production, there were still fewer days of critical oxygen shortages after the intervention. So the implications are that probably for patient outcomes, a target between 90 to 96% or somewhere in that range is likely good. And that in resource variable settings, it probably is really important to go with some saturation target in that range in order to conserve oxygen and make more available for more patients. So finally, I just want to talk about continuous versus intermittent pulse oximetry. And I'll just say briefly that continuous is obviously ideal so that you can be following a patient at all times. And with intermittent oximetry, you can certainly miss a period of hypoxemia. A few things that can be done to help with this, and just to be aware of it in high income settings, in the ICU, this is always done continuously, but in the wards, in fact, many patients only get intermittent checks of their oximetry. Not everyone is on a continuous monitor. Things that you can do to mitigate the risks of hypoxemia are to establish set intervals for monitoring. So for instance, making sure that every 4 hours or every nursing shift, there is a system in place for monitoring oximetry. Also, you need to have a charting mechanism that works. You may find in many places there are charts that have a place, for instance, for saturation, but no place to actually chart how much oxygen a patient's on. And both of those are important, again, in terms of setting up systems that allow people to do their jobs and to monitor. And then finally, I would argue you may want to go with slightly higher saturation goals in these settings, because you at least have less chance of hypoxemia if you're starting at a bit of a higher goal. That would be an argument perhaps for doing 92 to 96% instead of 90%. So these are the topics we've covered within oximetry. And again, the takeaways that pulse oximetry, with the caveats that Dr. Bickler mentioned, certainly is not perfect, but it is a reasonable alternative and a way to monitor patients with COVID-19 acute respiratory failure. That oxygen saturation targets somewhere in the 90 to 96% range are likely good both for individual patients as well as populations of patients and resources. And finally, that intermittent pulse oximetry certainly can be used, and it's good to set up systems in place so that hypoxemia is measured on a regular basis. And that's all we have for now. Thank you.
Thanks very much, Dr. Riviello. So we'll now transition into the Q&A portion of the presentation. So please put your questions into the chat or in the Q&A, and we'll go ahead and start chipping away at those. This first question, I think multiple panelists likely will want to react to. So as a clinician taking care of patients whose population includes those with dark skin pigmentation, what should the take-home messages be in light of recent data and the data that you presented from 2005? Dr. Bickler, I don't know if you want to start off with that, and then maybe we could get the perspectives of some of the other clinicians on the phone.
Sure. So even the world's best pulse oximeters currently read a little high on patients with darkly pigmented skin. The amount of error, though, is relatively small. At lower saturation, that error becomes larger. And so clinicians need to understand that this is a potential error when dealing with especially very dark skin. But I think the most important issue with pulse oximeter performance is perfusion. You've got to make sure, or at least try very hard, to make sure that the signal you're getting is good. You want to, in a patient whose oxygen status is uncertain, you want to warm the finger, you want to limit motion, and you want to make sure that the device is applied carefully. And finally, that you observe the performance of the device over a sufficient period of time. So those factors can be critically important in getting a reliable reading. And then finally, use the change in the oximeter's reading over time as a way of assessing what's happening, so that you're not using a single snapshot of oximetry readings. Those can improve the reliability of pulse oximeter readings in anybody, and especially in subjects with dark skin. And there are going to have to be technological fixes to this. There have been a number of things proposed there. It's technically possible to have some sort of detector built into the pulse oximeter, which applies a different algorithm in dark skin versus lightly pigmented skin. I think that's one way forward. There are a number of others that involve technical fixes with the type of light emitting diodes that are used and so on. So there's a lot of work to do.
Thanks, Dr. Bickler. Dr. Waweru-Sika, do you have any comment or reaction? What has been the response to the recent study and other studies in your practice setting, if you wouldn't mind commenting?
Yeah, thank you. So the recent paper sort of echoed what we've been seeing for a while. We had noticed in critical care that we would get blood gas results from a patient, and the PO2 would be lower than what the pulse oximetry is suggesting the patient is doing. And very often would try and troubleshoot and think there's a problem with sampling perhaps. And so the paper sort of suggested that what we were seeing was not an error in terms of sampling, the blood gas sampling, but was definitely something to do with our population. I think what isn't answered, and I think I do like the suggestion that perhaps it's more than just pigmentation, it's also perfusion. Perfusion, of course, is one of the core things you need to think about in pulse oximetry. If you have a dark-skinned person who's well perfused versus a dark-skinned person who's not very well perfused, is there a difference? And also what we also say is that we are dark-skinned, but we are also very different shades of dark skin. So what spectrum are we talking about? We have very light-skinned Black populations, and we have much darker ones. Is the variation the same? So I think that it does raise an interesting discussion, but we need to potentially look into it a bit further before we are able to conclude. But generally, we have targeted higher saturations, 94% and above. And for our COVID patients, we've been targeting 88 to 92% during the pandemic. Thank you.
Thank you very much. Do any of the other panelists want to add on that question before we move on? Okay. The next question, which I briefly answered in the chat, summarizing the findings about low-cost oximeters, how reliable are they? Dr. Riviello or Dr. Togiru Mugabe, do you have any comment on perhaps how commonplace it is to be seeing inexpensive oximeters, which are usually the finger oximeters, in practice, and anything that you've noted with regard to using them in clinical practice?
I'll defer to you, Dr. Teo.
Thank you very much. So I think the pulse oximeter has shown some good results in terms of life saving, especially in low income countries, especially those low cost, because they are easily available in every single setting. And then in my experience, we have never experienced such a big problem with those low cost pulse oximetry. And I don't think it is the time to reject them. And even if it happens that they're in dark skin, again, dark skin may differ from one person to another, we may see how we can review the targets instead of rejecting those low cost pulse oximetry, but they still need to be tested in terms of their accuracy.
Thank you for that. Just to add on to that, in the chat that I had answered, I just wanted to quickly comment, it depends on your interpretation of the data, if you're a glass half full or a glass half empty. The paper that we highlighted looking at low cost oximeters, those that had not been approved by validation studies, half of them did quite well in their performance. So it's not, the take home message is not that all of those should be discarded, especially because often those are what is available. So I do want to highlight that. To the point of the question that was asked about how reliable are they, it is variable. The accuracy, in order to get an approval from a governing body like the Food and Drug Administration in the US, for example, would be 3% in either direction effectively. Now, if you don't meet 3% in either direction and you're 4%, then technically that wouldn't meet the cutoff. But does that mean that it's not clinically useful? Probably not, especially when following trends. What is the clinical impact if your patient is setting 76% when in fact it's 80 or 81 or 4 points in the other direction? So Dr. Teo, completely agree, and just wanted to highlight that the important part is that just to be aware that the differences exist, but that doesn't, we weren't intending to imply with that study that all oximeters should be disregarded. So moving on to, Dr. Bickler, did you want to add anything to that? I saw that you'd come off mute for a minute.
No, I think Dr. Teo's point about not throwing the baby out with the bathwater is really important. I mean, at this point in the pandemic, we want to encourage oximetry. broadly. And I think the message that oximetry is important and useful should be the dominant one. And the concerns about performance should be a footnote compared to the imperative of getting oximeters more broadly into clinical practice where they're needed.
Thank you for that. Additional question here. Do you think that in part as a pressure of the COVID era, the inexpensive pulse oximeters are now in home-based monitoring like a thermometer or home blood pressure monitoring? Recently, the WHO has recommended that for certain high-risk groups, home pulse oximetry monitoring should be implemented. Over to the panelists, if anybody has comments on either using this in practice or just general thoughts on the concept of using pulse oximetry more in the home setting.
I can comment on that. I think it's a terribly important suggestion. Especially in areas that are just experiencing a deluge of hypoxemic COVID patients, where hospitals can't accommodate all their admission. Triaging people to home care with a pulse oximeter is a very reasonable public health measure. Inexpensive oximeters are becoming much more broadly available. The pulse oximeter that's on the back of the Samsung smartphones are actually quite good. We evaluated them in the laboratory. They work great. They're pretty good. If you use them carefully, they're great. I mean, the Samsung software is not great. It needs to be improved. But the pulse oximetry chip that's in that device performs quite well. It's really an advance. So smartphone-based pulse oximetry is a very important development.
Dr. Teo, did you want to comment on that as well?
Yeah, I think that's a great idea because not rather than last week, I have experienced 2 patients with COVID-19 who were likely to be well, but when I put the pulse oximeter, I found that the SAT was below 70. So, and those kind of patients may deteriorate quite rapidly. If it was possible to monitor the SAT at home, maybe they should have saved so many people who, because we have had some people who died at home-based care. So that those 2 patients are just very good examples that with COVID-19, the saturation can be something that should be monitored continuously at home, and then it can be an alert to call for the healthcare professionals to help those people.
Thanks, Dr. Teo. And as we wrap up, one final question here. The results of studies on investing in pulse oximetry and oxygen have been mixed, especially regarding newborn and child mortality. What do you consider as additional important factors to consider beyond pulse oximetry and oxygen supply in order to get good outcomes in hypoxemic patients? So perhaps to phrase differently, as we're facing a lot of burden of disease from hypoxia and COVID-19, the focus has been oxygen supply, ventilators, pulse ox, some of these very visible aspects of care. What are other fundamentals that that you, in under a minute, would summarize as areas to focus on, other than these quite visible elements of hypoxia management? Beth, do you want to comment on that, Dr. Riviello?
Sure. Yeah. I mean, I'd argue that if we could get those right, we're in good shape. I think pulse oximetry and availability of oxygen are actually at the core. And frankly, it's taken us as a world community a long time to get to that. I think we sort of started with ventilators and worked backwards. So I think pulse oximetry systems in place to use it to monitor, to titrate oxygen, and then availability of oxygen, I think can make a huge difference. The other piece is probably what we know in critical care, which can apply also to patients before they're in the ICU, which is the basic care of patients, monitoring, prophylaxis, sort of what I call the same way every time for every patient. those sorts of systems for baseline fundamental care, which include, for instance, prophylaxis for blood clots and that sort of thing. Those are the things I think that in addition to oxygen might be what could make a difference for patients currently.
Thanks very much. And that brings us to the top of the hour. I'd like to thank our panelists, Dr. Riviello, Dr. Bickler, Dr. Waweru Sika, and Dr. Twagiru Mugabe for joining us today. Please be in touch if you have any questions or would like a copy of the videos. And thank you again to USAID and STAR for supporting this webinar. Have a great day. Take care. Thank you.